the day of conversation going here, and this is a topic that I'm really, really excited about. It's one that hits personally for me because when I was diagnosed with my eating disorder, I was also diagnosed with OCD. So I kind of found myself often kind of, with both of them dancing around up there in my head and having to decipher what's the eating disorder voice, what's the OCD voice, and it was definitely very difficult. So I'm excited to talk with Katie and Lizette here today from IOCDF. Welcome to both of you. Would you like to go ahead and introduce yourself? Lizette, you're on the screen first for me, so I'll go ahead and pass it off to you first.
All right, thank you. Thanks, Jason. Thank you so much for having us. So my name is Dr. Lizette Cortez. I'm a licensed psychologist in Florida and certified eating disorder specialist. And I have a practice that primarily sees clients who have the comorbidity of OCD and eating disorders. So definitely this is what I'm very passionate about and I love to really work with. And in the past over a year or so, Katie and I have worked on a special interest group or are part of a special interest group at the IOCDF for eating disorders and OCD. So we spearhead that group, and it's for clinicians and people with lived experience. And yeah, I'll pass it over to Katie.
Thanks, Lizette. So my name is Katie Jeffrey. I'm a registered dietitian nutritionist. I have my own private practice as well and also work with compassionate healing with Lizette. I am passionate about also working with individuals with eating disorders and the comorbidity of OCD and eating disorders. And I also specialize in sports nutrition as a board certified specialist in sports dietetics.
All right, awesome. Well, welcome in. Again, thank you for the special interest group. And I'm really excited because next month I get to speak with the special interest group. So we're keeping this collaboration going. But let's go ahead and get the conversation started here today. So there are a lot of misconceptions around OCD. So I was wondering if you could maybe just dive into OCD a little bit more and explain, what OCD is, and maybe try to tackle some of that stigma and those stereotypes that exist around the condition.
Well, let me just kick it off by saying that one of my pet peeves is when people say, "Oh, I'm just so OCD," like they use it as an adjective when it really isn't. OCD is a serious condition, mental health and neurobiological. That is not just about being very clean or very organized or, very particular. Not so much, and I think that's something that we see a lot in like social media and like pop culture that refer to OCD in those types of ways, when in reality OCD can look like so many different things. There's so many what we call themes of OCD, right? And of course food and eating is one of them, but there's harm concerns, there's sexual orientation OCD, there are many different types of OCD. And primarily what we see, right, is this presence of intrusive thoughts, repetitive thoughts that are ego dystonic, which means that people don't really want to think these types of ways. And therefore, it feels very distressing, very anxiety provoking. And then on the flip side, people will engage in compulsions or behaviors, rituals to try to, appease the anxiety that is related to these thoughts, try to neutralize these thoughts, try to get rid of the thoughts. And so there's kind of like this continuous, like almost like cycle, right, of intrusive thought comes up and I do this type of ritual, and it's never like fully enough. And that's why compulsions, are compulsive. They continue to happen. They don't really ever stop. And so for people, it feels really distressing. Like, I don't want to think this way. I don't want to feel this way. This is not who I am. But there is that significant symptom of doubt or concern of, intolerance for uncertainty that feels like, well, I have to make sure that I'm not this way, or I have to make sure that I don't think this way. And I think that's kind of like the main component of OCD that oftentimes we don't talk about so much.
Yeah, and so now if we kind of shift the conversation from OCD to OCD and eating disorders. So are there some statistics out there that maybe you'd be able to share when it comes to the co-occurring instances of OCD and eating disorders?
Yeah, there actually are. Dizette and I pulled together a few. So, according to research, about 18% of individuals worldwide with an eating disorder had a lifetime prevalence of obsessive compulsive disorder. And then 15% of those individuals had a current comorbidity with OCD. So the numbers are pretty high with the comorbidity. And just to help other people understand, like how many people also have OCD, the research shows that about between 2 to 3% of the population at some point in their lifetime is impacted by OCD. And it's the fourth most common mental disorder as well. So very significant for many individuals.
Do you find that because like in it's I can't talk today, which is not good because it's the day of conversation. But do you find that there's often individuals like myself where it's like very cloudy between the OCD and the eating disorder, where it's very difficult for providers to really be able to identify what we're talking about here because there is so much overlap, especially when you look at different types of eating disorders and then you look at OCD.
Yeah, definitely. I think as you're speaking, Jason, I'm thinking about, when we try to differentiate, like, what are we really trying to get to, right? Um, from on one end, I think it is helpful to have a clear diagnosis of what's going on, with the purpose of providing that person with the appropriate care. you
Mhm.
know a lot of times it's really about, oh, this person's having some eating concerns, some eating fears, and therefore let's make sure we have a team, we have a dietitian on board like Katie, address this. Well, on the other hand, sometimes we don't want to get caught in the weeds of trying to spend so much time in, like, oh, is this really this or really the other,
Mhm.
where it kind of distracts from the purpose of really being able to provide good care.
Mhm.
Um, I hope, yeah.
Yeah, yeah, that's really helpful. And I'm also curious, kind of what's the research that's being done right now around around OCD and also OCD and eating disorders?
I think unfortunately there's not a lot of research out there, not for like the statistics that Katie just shared with us, right? We would think there would be a lot more literature around this. And I think, from my understanding, a lot of the literature is also really mostly focused on anorexia and bulimia, when we know that OSFED is the most common eating disorder, right? A lot of times it goes like under the radar because it's like not near here nor there. But when we have a lot of people who have OCD and have fears of food or eating concerns, they tend to fall into that OSFED diagnosis as well.
And could you expand on that? Because that's the first time we've mentioned OSFED so far today. So could you expand on what that diagnosis is?
Yeah, sure, sure. So OSFED is basically when people don't meet full criteria for anorexia, bulimia, binge eating, but they do have certain features or traits or certain symptoms of this criteria. They fall into what we call the other specified feeding and eating disorder, sorry. And therefore, at times, people might not say, well, I don't have anorexia, so I don't have an eating disorder, but I do restrict or I skip meals, So there's definitely those pieces that, like I said, like oftentimes get misdiagnosed or fly under the radar, because they don't meet full criteria for, other eating disorders.
Yeah, yeah, and that's a good point. I'm gonna go off on a little tangent here really quick, but it's one of the things that people might even see the name of our organization, the National Association of Anorexia Nervosa and Associated Disorders, and say, "Oh, well, anorexia is the most serious, and everything else is kind of, just other." But any type of eating disorder is serious. Our name just is because we were founded back in the 70s when anorexia was the only thing in the DSM at that point. But it's important that we realize that any type of eating concern, any disordered eating whatsoever, definitely deserves attention and deserves help. And everybody is worthy of healing and reaching out to somebody, because I know that there are individuals out there right now who are listening who are probably like, I'm not sick enough. I'm not that bad. I don't need to get help. But if diet, exercise, if any of that is starting to get in the way of your life, then it's time to talk to somebody. All right. So I kind of want to move a little bit now into food aversion when it comes to eating disorders and OCD. And I know that another one of the types of eating disorders that often doesn't get talked about enough, but it's starting to get talked about more, is ARFID. So I'm curious, where does that fit into the whole OCD and eating disorder puzzle?
Yeah, it is another type of eating disorder. So it's avoidant restrictive food intake disorder is what the ARFID stands for. And it has to do with either aversions of different textures, smells, temperature, the look of a food. It can also be due to aversions of particular bodily sensations. So like the fear of vomiting or the fear of having nausea or different other physical symptoms due to eating. And the last one is just a disinterest in food in and of itself. And individuals can have either one of those criteria or maybe all three, just based upon how their particular symptoms are presenting. And so Lizette and I have worked with many individuals who would meet the criteria for ARFID and also have OCD. And the main thing that we want to think about is that what is really driving the individual's behavior. We want to get at what we refer to as the core fear. Because if someone is restricting food, we want to see like, well, why are they restricting food? And if we don't stay open and continue to ask, say, open-ended questions to really get at that core fear, we may not be able to give them the most effective care. So for example, if someone is, say, where, they're letting us know that they're maybe skipping breakfast, and we're just assuming, because they want to change their body weight, shape, and size, when actually when we start to ask more in-depth questions, we recognize that maybe their core fear is that they actually don't eat breakfast because they have a fear that there's bugs in their food, and it's really tough for them to eat particular breakfast foods because those foods, just for some reason, OCD is attached to them, and they feel like, say, oatmeal, with raisins, right, more looks like that there's bugs in their food. And again, that would be an OCD presentation. But again, if we're looking at that core fear, we're looking at, why are they restricting that particular food, or why do they have an aversion to food or textures? So again, it can be very cloudy and complicated. So again, coming back to like, what's the core fear, it can be very, very helpful when we design or help brainstorm with the client different things to do to help them to increase the amount of food that they're consuming and also increase the variety of food if that's one of their goals.
Yeah, amazing. And that plays into a little bit of my personal experience, because I battled orthorexia, and I had this fear of contamination around food, where it was like I was more focused on the quality of the food that I was eating rather than the quantity of the food that I was eating. And so I can very much relate to that, where there was just this overwhelming fear that what was on the plate in front of me would immediately cause disease, or that it was going to pretty much poison my body. So it was one of those things where there was definitely that food aversion that was going on. And I know that, again, it doesn't really matter exactly what the diagnosis was, but it was one of those things people were talking about, like, where does orthorexia fall on this whole spectrum when it comes to eating disorders? Does it lean more towards ARFID, or is it kind of more OSFED and on its own? So it's one of those things where a lot of diagnosis will not fit into a little box. It may, reach across several different types of eating disorders.
Yeah, and Jason, I think it's so interesting that you mentioned that, because I think most people tend to be familiar with the term orthorexia, and we speak about it clinically. And if I tell someone, they know what I'm referring to, and yet it's not a diagnosis.
Right.
It's not in the DSM, and I think kind of like what Katie was mentioning, it can look many types of ways, and like you're saying, like, and connect to different diagnoses. So it's so important to really ask more questions and to really look at the core of like, why are people avoiding certain types of foods? Because the same behaviors can have such different reasons. I think that that's what makes it tricky. And my gosh, I imagine in your experience, so tough, right? The fear of contamination, and that I think goes more into the OCD, and the fear of harm to self, um, and maybe avoiding certain foods that didn't feel so safe. Um, and yet, we can see that also in ARFID, where people feel fear that they might get, something stuck in their throat, or something might harm or give them a stomach ache. And then we might say, oh yes, this is ARFID, but it can easily fall into different categories.
Yeah, I'm wondering, and this is one of those things where I still have a lot to learn when it comes to OCD too. But I've heard it passed around out there before around health OCD, where it's kind of OCD related to your health and kind of almost related to the health anxiety that a lot of people might experience. Is that really a thing, or like, could you maybe expand a little bit more on that aspect of things?
Mm-hmm. Yeah, take that, Katie.
Oh, you want no? Go ahead, Lizette. I'll follow you.
Okay, so yes, the quick answer is yes.
So health, yeah.
I think we're kind of having a little bit of a lag, and I apologize. I don't know if it's me, or I don't know if his internet is not cooperating. But I'll jump in. So the quick answer is yes. We have a lot of different ways in which health OCD can present. It could be in regards to specific, like, will I throw up? Will I get a headache? Will I have the flu? Like something very like immediate, to like, am I developing heart disease? Will I develop diabetes? Will this give me cancer? It's something a little more like, let's call it like down the road. But either way, it feels as though the harm is very imminent. And people can feel very overwhelmed and feeling like they have to prevent this at all costs, and they have to prevent it like now, right? So I think there's lots of pressure that people feel, that they have to be in control of things, and they have to be very cautious. They have to check and reassure themselves around it. Just trying to make sure, right, that they're not doing something that could potentially put them at risk of harm. Um, so although different people might experience different types of health OCD, there's definitely that significant component of the fear and the trying to prevent harm from happening.
All right, Katie, and did you have something that you wanted to add too? I know we had a little bit of a mix up there with the communication for a minute.
Oh yeah, no worries. No, Lizette covered it very well. It's just that coming back to that uncertainty and core fear of, if I do this, will I then develop cancer or heart disease, or will I throw up? That doubting that really happens so much in OCD. That is very distressing for individuals.
Yeah. Well, thank you for sharing that. To get kind of back into RFID again, really quick, and we're going to have a conversation later on today about RFID too. So if you're interested in learning more about this topic, definitely tune back in a little bit later on, as well as orthorexia, because I'll be sharing my story a little bit later. But as far as around RFID, what's the difference between picky eating and RFID? What are maybe some warning signs that parents could be on the lookout for their children, or loved ones could be on the lookout for their friends or their family members? Where do you kind of draw the line there?
I think the main difference is the amount of impact that behaviors have on the person's, stability, functionality. I think part of it though has to do with like you might see someone who has preferences or would rather not eat certain things, or let's say enjoys, this particular types of foods, but they might have flexibility and be able to say, yeah, but once in a while do try this, or sure, I'll take a bite of that, and have that ability to kind of step outside of the box. But when someone has ARFID, there is a huge component of fear that keeps the person within that box, right? Says, no, there's no way I can try that. Or, I might avoid going to a friend's house because they might have this and that and the other. Or I might not engage in these types of activities because I don't want to be around this kind of foods. It's a very much more significant impact than I would say like picky eating. Um, and it goes beyond the preference, right? It's more of a must, and it feels very distressing to even try to do something outside of what feels safe. So, but good question, because I think a lot of times we get, especially parents, when we see our fitting like kids, we get parents who might say, oh, my kid's a picky eater, oh, they're just difficult, or they're not, they're not willing to eat what the rest of the family eats, and mind you, our fit is not just in kids. I think that's a big misconception that only kids have our fit. Definitely not. Adults can have our fit too, but there's definitely a big difference between, oh, my kid prefers certain stuff, or my spouse, my friend who prefers certain stuff, versus this is the one thing that they feel is okay, safe, palatable, right? Won't cause them to choke. There's definitely that difference between the two.
Mhm. Yeah, and one other area I wanted to explore, and this is an area that IOCDF does a lot of work in, but it's around body dysmorphic disorder. And I know that you host a conference every year on that, and just really, really explore that topic a lot. So I was wondering if you could maybe expand a little bit more on BDD.
Yeah, definitely. I think to start off with, though, I do want to say there's a pretty big difference between body image concerns and like negative body image and body dysmorphic disorder. You know, and I think it's tricky because a lot of people do refer to body image concerns as like body dysmorphia. They might say, "Oh, I have body dysmorphia," but and that's valid, don't get me wrong, but I think when we're talking about specifically like BDD, it goes a little bit beyond, um, I have body image concerns and dislike for my body as a whole, versus when it is BDD, people tend to be more focused on a specific body part. A lot of times in the face, like the nose, the ears, the mouth, the hair. We've worked with people who have BDD about their hair before, um, and is very, very, very distressing. And just how we see in OCD, no matter how much a person tries to like fix it, change it, do something about it, it never feels like enough. And that creates a lot of the stress for someone. Um, but it's different because oftentimes, if someone has an eating disorder, is usually around like their entire body shape and size, right? They feel those negative self-evaluations around kind of like general picture, and they have negative body image, right? And then when we are seeing BDD and we're talking about like something specific about their bodies, that's where we can start to see the differences in like diagnoses, and perhaps understands like, oh wow, this goes a little bit beyond like an eating disorder, and it's looking more like body dysmorphic disorder.
Excellent. And I know for folks who are listening right now who might be interested in learning more about that, you'll have the virtual conference coming up. I think it's at the end of May. Is that correct?
I believe so.
Yeah, you've got so many amazing conferences coming up that it's always hard to remember exactly when everything is, but definitely go to the IOCDF website and check that out. Because it's a really interesting area to explore. And I think it's another thing that often gets overlooked and not talked about near enough. So I really appreciate that you all have that resource available and that you do so much work in that area.
Thanks for the shout out, definitely.
For sure. So let's see. Moving along here, I'm curious. We kind of already touched upon this from an RFID perspective, but are there any other maybe warning signs that friends, family, parents, loved ones should be on the lookout for when it comes to an individual, one maybe exhibiting OCD warning signs, but also exhibiting eating disorder warning signs, or vice versa. So, I'm curious if you've got any suggestions on what people should look out for.
I can cover the ones for eating disorder. And again, it could be stemming from OCD as well, when I talk about these different kind of warning signs or symptoms or behaviors. So one is just to kind of see, like, is someone's behavior, or what we say the relationship with food or eating, has it shifted? Maybe gradually over time, or maybe pretty suddenly due to a new fear popping up. And that's someone where loved ones or friends could even say, hey, like, just thinking about, like, they used to eat these particular foods, and now all of a sudden or gradually over time, they've stopped eating a particular food or a particular whole food group. So again, any changes like that could be just, maybe questioning the individual, asking them about that with an open mind, with compassion. And then other things. So again, the food avoidance, whether the individual has any food fears that are coming through. And again, it's asking questions, because someone could just say, oh, I just don't want to eat it anymore. But again, just asking a little more questions around that. Has just the food no longer appeals to you, or is it deeper than that? And is there a fear associated with consuming that particular food for some reason now that has started to happen for that individual? And then just concerns around, like, so changes in their eating habits. So such as, like, is the individual now skipping certain meals, or have their meals really decreased in size? Are they avoiding food groups, or eating desserts or different snacks? Are they avoiding eating in certain social situations because they may be a little bit nervous to eat with other people because their eating behaviors have changed? And so they may no longer want to eat with other people because they know that maybe what they're doing they might feel a little bit shameful around it, or embarrassed that their food and eating behaviors have shifted. Excessive washing of hands or utensils, pots or pans. Again, that's very often a OCD component of it, with contamination OCD. But again, if food preparation is now taking longer than you've noticed before, again, just asking some questions around that. Is an individual all of a sudden, or again, gradually over time, starting to really check out their food when they get it? Looking for different, like, foreign objects or maybe bugs in their food. That can be a common obsession for individuals with OCD. Maybe excessively checking food labels to see, one, is the food, does it have any quote unquote contaminants in that I don't want to be putting in my body? Does it have a particular amount of fat or protein or carbohydrate that they're trying to steer clear of, or sodium that they're trying to reach this, like, certain amount that they feel is okay for their body? Counting of calories, starting to really be concerned with kind of the macros. That's one I've heard a lot recently, right? Counting macros, making sure they're hitting these very specific targets. And then just seeing, like, does food and eating, meals cause more distress for the individual? Is that now more of a scary, stressful time as opposed to a pleasurable time for the individual, and has that shifted? So those are just a few examples of things to be looking out for. I think the biggest thing, though, is underlying is, has the individual's behaviors around food and eating, has it started to shift or change over time? Important part.
Excellent. Yeah. Thank you. Lizette, did you have any thing that you wanted to add there?
Katie kind of, like, covered it all. Pretty awesome. But I might add, just because I know I've had some clients that feel they have to cook food in a certain type of way, or make sure it's well done, let's say, especially with, like, meats and things like that. And again, if there's, like, that doubt component of, I thought I cooked it enough, but maybe it needs to be more, and there's definitely a little bit of that as well, that sometimes we want to be on the lookout for cooking in a certain type of way.
Excellent. Yeah. Thank you.
Yeah, that's a great one, Lizette, because that does often happen. And again, it's not until we ask the questions about, oh, why is it, like, why won't you, no longer eat at this particular restaurant or eat foods that other people have prepared? right? Kind of what's going on there, how I might be able to help you or support you or talk about it.
Oh, and one more that comes up, checking to make sure that the packages they buy are properly like sealed before they get home and like open them, right? That's something that also can come up. And it typically has to do with fears of contamination or something being in their food, like a foreign object, like Katie was mentioning.
Well, yeah, thank you for sharing all those. The one thing that I've learned today is that for dietitians, it's often got to be the same thing that they taught me when I was taking journalism class. Ask the open-ended questions, because that's going to help you find out so much. So I have a newfound respect today for the open-ended question. Okay. So people maybe have seen the warning signs. So now what? What type of treatment options are available? What are the next steps that an individual should expect? If warning signs have come up and now you've got to start to have some of those challenging conversations at times, what kind of treatment options are out there? What resources exist?
So to give a bit of background, right now, research shows that unfortunately, it often takes years for people to be properly diagnosed. So specifically looking for treatment means, looking for someone who is trained in identifying and assessing OCD, because oftentimes it can be diagnosed as something else, misdiagnosed altogether, missed. Um, so looking for someone who has experience with fears, anxiety, like that's a good place to start, right? An OCD specialist who can really do a thorough assessment can help people get to the proper diagnosis quicker. And I mean, we're trying, the field's moving forward, but we still got a ways to go, definitely. And I think this is why I'm so grateful for conversations like this one, where we can really get the word out there and people become more aware what to look for, or they might be experiencing certain symptoms and they may not know what they are, but resources like the iocdf.org can help people understand what they're going through a little bit better. So understanding and awareness, I think, is kind of like the foundation first of all. But in regards to treatment, so exposure and response prevention is the gold standard of treatment for OCD. And that is a kind of offshoot of cognitive behavioral therapy, or CBT. And it's a very hands-on type of treatment where people's fears, concerns, get assessed, and gradually, or at least systematically, doesn't have to specifically be in an order, but systematically, people are able to face their fears, lean into discomfort, learn to tolerate uncertainty to a better degree, and be able to really tap into their values, right? To make choices that align with those, and and not choices that are driven by like fear or concerns. So I think those are some of the goals of treatment of exposure and response prevention. And um, other kind of auxiliary treatments like mindfulness or ACT oftentimes are also helpful for people who are experiencing these kind of symptoms. And specifically when there are fears of eating, food concerns, etc., working with a dietitian who understands OCD is very important, who is going to help them really be able to challenge these fears and not reinforce or the compulsions or the safety behaviors that might go around that. And Katie, maybe you can share a little bit of what that's like on your end.
Sure. Yeah. No, you covered that very well. So when I'm working with someone, as Jason has pointed out, asking lots of open-ended questions and coming from a place of compassion, because many of these individuals are embarrassed or feel ashamed with the behaviors that they're currently doing. And really their behaviors, again, as a way to cope with the distress that they're feeling. So it's a way to help them to feel safer in their environment and in their bodies. And so letting them know, once the individual, say, is diagnosed with OCD and some food fears, let them know that they're not alone, that they're not the only individuals that are experiencing this, that I work with many individuals who have these fears. And it's tough stuff to be able to do these exposures, that is hard work, and can help them to get their life back, to live a full life, to be able to eat the foods that they love to eat and want to be eating. And so that's so helpful. So throughout my sessions, again, asking open-ended questions, really making sure as a dietitian to see like what currently are they consuming? Are they consuming an adequate amount of energy for their needs? Do they have any nutrition deficiencies? So blood work is always very helpful in my initial assessment. Working with a medical doctor as well, to make sure that they're medically stable, because we want to ensure that the individual is medically stable in order to do the hard work of ERP. And so it's helpful. And they can be moving towards medical stability based upon where they are kind of in that range. But we do want to help them to get to that point sooner rather than later, so that they can engage as effectively as possible in therapy. And then as I'm working with the individual, again, the first thing is to help them consume enough energy for their needs, and then gradually moving into increasing their food variety, which is very helpful. And then from there, as I'm working with the individual, I'm really using, at least in my practice, I use a lot of ACT and self-compassion and mindfulness, bringing in the values, so that they can make decisions that are more often aligned with their values and less aligned with OCD and food fears, is so helpful for them. And so we're creating exposures as a team so that they can, again, build their food repertoire and start to enjoy food again. One of the things I continue to come back to with many of my clients is, rather than having, say, nutrition or food fear dictate what to eat, what foods do you love? What taste do you want to eat? What are the foods that you really love to eat and really enjoy before these fears kind of settled into your life? And can we help you to increase your enjoyment with food again as much as possible? And facing those fears can be very challenging, and having the support of myself and a therapist, a medical doctor, and then their own support team, say a loved one, family members, friends, is also very helpful in that process.
Yeah. And here at ANAD, from time to time, we will do pop-up support groups too, for OCD and eating disorders. So I had the opportunity to lead one of those groups late last year, and it was a phenomenal just resource to have, in addition to everything else that you might be doing with a dietitian or with a therapist or whatnot. And I also kind of wanted to echo again that value-based approach, because for me, it was so beneficial when my providers would talk to me about my values or who I was or my interest or my strengths, because that made me feel involved and engaged in the recovery process. And I think that was so important. So I always tell any provider who's listening to make sure to get to know the person that you're working with. Don't just look at the condition that you're trying to treat, look at the person and get to know that person, because it's so important. So let's see. Anything else that you want to cover? I know one other question that I had around the treatment is, what does eating disorder recovery look like for an individual who is learning to live with OCD as well? How does it maybe differ from an individual who doesn't have OCD?
I think that I've thought about this quite a bit, because in the work that I do, thinking about, there's still a part of me that presents in a session differently when I'm working with an eating disorder than when I'm working with OCD. And that to me lets me know eating disorder treatment does look a little different. We do have to go into a few more things, I think, than when we're working on just strictly OCD. And some of what comes to mind are, the fact that in eating disorders, a lot of time thoughts are egocentric. They go with me. Yes, I do want to change my body. Yes, this does look like something I want to get rid of. Or yes, I do need to make these behaviors be this type of way. When in OCD, it's a lot more like, oh, I don't want to think like that. Like, why does this thought keep popping up, and I want to push it away? And a lot of times when we are working with those egocentric thoughts, maybe belief systems that come up for a person, there's a lot of work to be done around, where do these even begin? how did you learn that this was like not okay for you or inappropriate or you needed to change it? I think there's also a really significant component around social justice that I think is important to address when we are working on eating disorder recovery. You know, uh, just really tapping into diet culture, the effects of diet culture on the person, fat phobia, all of these pieces that drive a lot of those egocentric type thoughts. So part of it is when someone is recovering from an eating disorder, we want them to feel empowered to kind of like reclaim their being, right? And being able to make more peace with their bodies and have time to maybe grieve the things they don't like or understand why they feel the way that they do. There's a lot of those components, I think, that perhaps when someone is, you know, recovering from OCD, maybe they don't necessarily have those kind of distressful pieces in, you know, in their presentation. And I think it is something that as eating disorder clinicians, we need to make room for in our office when we are working with people who have eating disorders.
Yeah, Katie, did you have anything you wanted to add there?
I think for me as a dietitian, when I'm working with someone with an eating disorder as opposed to the comorbidity, it's very similar to Lizette in the fact that in my scope, really helping someone to form a more peaceful relationship with food and their body as best as possible, and knowing that they may never get to acceptance. However, for many, the intention is at least self-respect. So respecting their bodies, respecting the way that they're able to fuel and nourish their bodies in a way that allows them to live a vibrant life for whatever health means to them, because what health means to every individual is very different and unique, and we also want to honor that. And so I'm also asking questions about what does health mean to you, not what diet culture is telling us, not what someone else is telling us, but what does that look like for you? And so really, again, getting at what is going to resonate with them to help them to fuel and nourish their bodies in ways that is adequate and also works for their overall being as an individual. So really talking about the stigma that diet culture can have around food in our bodies and helping them to move away from black and white, all or nothing thinking to a gray area. So often my clients, I talk about how can we help you to live more in the gray area of life when it comes to food and nutrition, as opposed to this black and white, all or nothing, good or bad. And so really helping individuals with that, or someone with OCD, they might not even have those thoughts, right? Because theirs is more maybe contamination, things like that, not having to do the same nutrition and diet culture. So it does look different, and there's also some similarities as well.
Yeah, thank you. Some of that you shared, I swear you stole it from my presentation later on today, talking about diet culture and the whole black or white thinking and all of that. So that resonates with me. So I think that pretty much covers the questions that I had that I really wanted to get out there today. The audience, anybody who's watching, wherever you're watching from, definitely feel free to comment and add a couple questions in the chats if you would like. There is one question on here already from Juliana, who asked, is there a correlation between celiac disease and ARFID? So I was wondering, Katie or Lizette, would you be able to maybe speak to that a little bit?
I am not aware of any, say, direct correlation or research that has been done with that. So I myself would have to do more research to see if there's, any, say, statistics or anything out there. I am wondering if a little bit, if it more may be driven by the fear that if I do consume foods with gluten because I have celiac disease, I may have X, Y, and Z symptoms, which are very real, right, for the individual. Because when someone has celiac disease, they need to avoid any food that contains gluten because they will have medical complications from consuming those foods. So I wonder if, again, looking at where the core fear is coming from, and that's a real fear for people when they have either allergies, food intolerances, celiac disease, something like that. And then that's where we want to help them. And as a dietitian, it's looking at kind of grieving with the individual, like, gosh, I'm so sorry, you can no longer eat these foods that you may love, or that they give you symptoms that you really would not like to be having. And then helping them to hopefully move to the acceptance piece and then find a way to be able to live a vibrant life with that particular diagnosis, because it is lifelong when someone either has food allergies, intolerances, or say celiac disease.
Yeah.
And I may want to add that going back to the question around health OCD or even like health anxiety, right? Um, as Katie mentioned, these are very real concerns. These are, if someone is diagnosed with celiac, we know that they are having symptoms. There's pain, there's discomfort, etc. And these are things that people do want to be careful around and watch out for. And that's adaptive, right? Just like anxiety is adaptive for us as human beings, it helps us. But when it becomes disproportionate to what's actually needed and what allows them to function, this is where we start to get into like muddy waters a little bit. Because if someone is perhaps compulsively checking to make sure that it doesn't have gluten, or that I'm not coming in contact, or that my friend didn't put my fork in gluten, things like that, then anxiety is getting higher, more rampant. We're actually reinforcing fears. People's functioning is also affected. And so we want to be careful, like Katie was mentioning. We want people to be able to have that flexibility of, I can try my best and I'm going to make mistakes. And when I do make mistakes, we work with it and we get through it and we get to the other side. Versus I have to make sure I am absolutely careful in every single situation, no matter what. And, I have to always be on top of it, and there is no room for mistakes. And that is a recipe for anxiety.
Yeah, and that's something that I can personally relate to. In the last year, I was diagnosed with diabetes. So I have now had to learn in my recovery to balance the food, kind of not restrictions, but the food guidance that I've got to follow in order to manage my diabetes, along with still manage my eating disorder recovery. And it's very tricky at times. And my dietitian said those exact words. She said, "You're not going to be perfect 100% of the time. Do not put that much pressure on yourself. Like, this is the guidance you need to follow to manage your diabetes, but it's not all black or white. It's not 100%." And she also kind of added that I would feel it. Like, if I wasn't necessarily maybe following the guidance, my body would let me know and tell me like it's time to reevaluate things. But the most important thing I think that I took away from my conversation with her on that was that I always just need to take a pause, even if it's just for a brief moment or two, and ask myself, where is this coming from? Where is this decision I'm making around food or what I'm going to eat today? Where is it coming from? Is it coming from a place where I want to take care of myself and manage that diabetes? Or is it coming from somewhere else? And if it's coming from somewhere else, then it's time to have some conversations and to explore that a little bit more. Yeah, and Lori posted in the chat, and this kind of relates to what we were just talking about, but is there any correlation between endocrine dysfunction and eating disorders? Such as, are you seeing any abuse of things like protein bars or energy drinks as meal replacements?
I would say yes, probably. This not my forte. I might let Katie take this one, but I mean, eating disorders can lead to endocrine dysfunction. Yes, um, but and then there's definitely lots of abuse of protein bars and shakes and meal replacements, as as kind of limiting food variety. That's definitely a symptom.
And also too, it's an easier way, or more of a surefire way to really know exactly what you're eating. When someone is in kind of the eating disorder, restrictive eating, right, they can much easier calculate a protein bar that has the nutrition label on there if they're like counting calories and counting different things, right? They know, like, okay, this is exactly what's in there. Again, there's probably always some error in that too, but that can be one reason why people can revert to more of those ready prepared foods with nutrition labels because of that. And just like anything, you can be consuming too much protein for your body in a way, in the fact that your bodies can handle that. However, when we're eating more protein than our body really needs, but also what happens is you don't have room for enough of the other nutrients that your body really wants and needs, such as carbohydrates and fats and fruits and vegetables. And so again, and desserts, right? And just all different foods. And so when one particular, say, macronutrient is much higher than the others, it can kind of skew things and, what is really meeting your energy needs and overall nutrition needs. So we just want to, again, have more of this gray area rather than extremes of one particular nutrient or even vitamin and mineral.
Yeah. Yeah, and I'm looking at all my gym bros out there right now, especially with the protein, because I've been there myself and I see it a lot. It comes up, especially in our men's support group, where there is this fixation around protein and everything else gets forgotten about. And that's not healthy. It's not good for our bodies to have just a one focus on a single macronutrient.
Right,
and not to go too much of a tangent, but going back to like BDD, body dysmorphic disorder, and there's often like muscle dysmorphia within that. And I think that's what you're maybe referring to, Jason. A lot of times, eating behaviors do shift and change because of fears that, my muscle tone is not what it should be or what I want it to be, etc.
Yeah, such an important topic. And that's one we can add for next year's day of conversation, because I think it is an area that we also have to explore. And it kind of goes back to what I said during our kickoff, but this is just the start of these conversations. We need to make sure we have these conversations every week of the year. Just because this is Eating Disorders Awareness Week doesn't mean this is the only week we're allowed to talk about eating disorders. It's something that the more we talk about, the more we're going to erase that stigma and erase those stereotypes that are preventing so many people from seeking the resources and the help that they deserve. So before we go ahead and wrap up this conversation today, I was wondering if you could maybe just share a little bit more about IOCDF, what the organization does, how people could get involved if they'd like to, get involved or volunteer or whatnot.
Yeah, so the IOCDF is the International OCD Foundation, and they're the leading organization in regards to OCD education, research, advocacy, outreach, support. They do all the things, and they're wonderful when it comes to training clinicians to really do evidence-based treatment and really do good work for these populations. Information is always changing and is being updated, and IOCDF does a great job at keeping up with all of that. We're very grateful that they've made room for a special interest group specifically on OCD and eating disorders, because Katie and I are definitely very passionate about that. And we're always welcoming people to join us. We meet the second Monday of the month from 12 to 1 Eastern Standard Time. And if you go to the iocdf.org, there is a tab where you would, scroll down to special interest groups. We pop up somewhere in there, and you can hit the fill out the interest form so you can get all our emails. But yeah, we're always open to having people joining us.
Yeah, and you should come join us for the March one, because I'll be there.
That's great. You're awesome.
I'm really excited for that.
Yes,
yeah.
Awesome. And and we've got some really good conferences coming up too. I know the conference will be in Chicago this July. I'm looking forward to being there, and it's going to be a part of that. So we're looking forward to the conference as well.
Excellent.
Yeah, I just wanted to add the IOCDF website is so comprehensive. There's so much information on there. If you're also looking for a therapist or clinician that specializes in OCD, there's a find search as well. You can do lots of different criteria, insurance, no insurance. So that can be very helpful for individuals. And they have a couple of different offshoots too: anxiety in the classroom, anxiety in athletes. So just so many wonderful resources that the IOCDF does. They're just a wealth of information and research. So we're very grateful for them.
Excellent. Well, thank you so much for everything that you do. So before we wrap up here today, I've got to ask, I've been trying to ask as many people as I can, because we recorded a couple of these conversations ahead of time. But what is one thing you want other people to know about eating disorders? So we've just had an awesome conversation full of things that people should know about eating disorders. But if there's one soundbite, one takeaway for each of you, what would that be?
I would say, because this just came up in a conversation from yesterday, that eating disorders don't look any certain type of way. You cannot tell if a person has an eating disorder or not by just looking at them. And that's a big misconception that I think that we really need to cut out.
So Lizette, I have to laugh because that's exactly what I was going to say as well.
Oh, really?
Yeah, there's so much stigma that an individual, because they've been noticed, they look a certain way, and then people who are really suffering are going under the radar or thinking they're not, quote, sick enough to be able to get help and support that they deserve. And so I think that's really important for individuals and clinicians, professionals to know as well, that the eating disorder can look different for many different people, and it can affect everyone and at any age as well. I think those are the other important things too.
Yeah, and that's a really important one, and that's a topic that I hope to explore more too, especially around age, because I feel like there's this conception out there that eating disorders only happen to young people, but eating disorders do not discriminate, and they can happen at any age, and any age, any background, any identity, so it doesn't matter. And I think that is one of the most important things we can get out there this week, is just people know that it can happen to you. It can happen to a loved one. There is no stereotype. All right. Well, we are approaching the top of the hour here. So Katie and Lizette, I'm going to go ahead and thank you both for joining me today. And I will go ahead and start getting us ready for our next conversation. But again, thank you for the amazing work you're doing. And thank you for joining us for this conversation today.
Thank you so much for having us. Thank you for the space and for doing this kind of work and for, making it information available for people. That's great.
Yes, thank you so much. Really a pleasure, and keep doing the great work that you're doing.
All right. Well, thank you so much. I hope you both have a great rest of your day, and take care.
Thank you.
Thank you.
All right, everyone. So that was a pretty cool conversation, right? And we're just getting started here. We've got plenty of conversations left to go throughout the day. So this is just kind of a brief recap of where we stand right now. Coming up next, we're going to be joined by Rural Minds talking about eating disorders in small town America. And this is a conversation that I had the opportunity to record 2 weeks ago. And it's a really impactful conversation, one that I really learned a lot through my talk with Gideon and Chuck. So I'm excited to share that with you in a moment. Again, if you're watching on the ANAD website or on our social pages throughout the day, we're going to continue to stream in those places. So the stream might go down for a minute. That's just because on the back end here, we've got to shut things down and then restart things. But you stay right where you're at, because you've got a prime seat to be a part of the conversation today. Also, continue to comment in the chats throughout the day. We are going to try to answer as many questions as we can. We want to make sure that this conversation feels inclusive and collaborative, and you are driving these conversations. So just keep that in mind as well. And then I also wanted to remind everybody, if you registered, you probably saw that we've got a really cool raffle going on right now. And our friends at Alsana, who are helping to sponsor today's event, they have a healing at home basket that's got some really cool things in there. I'm not going to lie. But if you'd like to go ahead and enter the raffle, we will pull the winner tomorrow. All proceeds go back to ANAD and help support our programs. They make our free peer support possible. So we are really appreciative for our friends at Alsana. Definitely go ahead, click that QR code up there in the corner and enter the raffle. It's a great way to give back to ANAD and to win some really cool things too. Like I said, I'm going to be jealous of the winner because there's some pretty nice items in there. So without further ado, we have hit the top of the hour. So I'm going to go ahead and pull up my video and my conversation with Chuck and Gideon. I'm excited for you to listen in. Now we're going to shift over to small town America, where unfortunately 46 million Americans face additional stigmas and barriers when it comes to seeking eating disorder treatment and support. But our friends at Rural Minds are working to change that. So I'm excited to welcome Chuck Strand, who is the executive director at their incredible organization, along with Gideon Whitehead, who has lived experience with anorexia and ARFID while living in rural America. So without further ado, let's get this conversation started. Gideon, I want to start this conversation off with having you share a little bit about your lived experience of being in a small town and battling an eating disorder and just kind of, take us into that experience and what that was like.
Yeah. So, I've born and raised in Western New York, so nowhere near the city. Um, and for me, I have two primary diagnoses, ARFID and anorexia. And with the ARFID specifically, the treatment already is very new with that. And at the time, while I was growing up, it wasn't even a diagnosis, officially in the DSM. And so a lot of it was just, well, if he gets hungry enough, he'll eat, which isn't really how ARFID works. And I consider myself very fortunate that I grew up with a family who kind of had the mentality of you know what? He's a weirdo, but he's our weirdo, and we will make sure he is fed.
Yeah, that's awesome. Could I ask for a minute, what is ARFID for folks who are listening right now who might not know what that is?
Yeah, so ARFID is avoidant restrictive food intake disorder. And there are a lot of subcategories of ARFID. For me specifically, it's tied closely to sensory issues. I am autistic, and unfortunately, meals and just food in general is a very sensory experience.
And so what was that like having, realizing that you've got ARFID and battling this in a small town? What were the resources like? Did you have to travel far to find assistance? Did you have to turn to the internet? What was that like?
So I ended up turning to the internet because, like, along with realizing, oh, I'm autistic, I realized I'm not the only one who, at the time, I classified it as I eat weird and I'm picky. So it was really beneficial to find a community of other people being like, oh, yeah, no, same. The
Yeah.
idea of wet pasta makes me want to cry. And I found that sense of community within it just because, you know, I wasn't the only one.
Yeah. And it's one of the interesting dynamics that I've come across is that eating disorders are so isolating. They already isolate you. So then if you're living in a smaller town, you feel even more isolated because you've got that physical isolation from folks, and it can be very difficult to find your community, even though you're in a town where oftentimes I think a lot of people, when we think small towns, we think community and everybody knows everybody and everybody's there to support everybody. But it can be very difficult when other people don't understand your experiences and what you're going through. So I would love to bring Chuck into the conversation here just to talk about, Gideon, you've already shared some of the barriers, but Chuck, what else are you seeing out there when it comes to folks accessing mental health support in rural America?
Well, there are a lot of challenges and barriers, both from the geographic, technology standpoint, but there's also lifestyle challenges. But I think at the top of that list, it's really the stigma that surrounds mental health, mental illness, and unlike diseases such as cancer, cardiovascular, or diabetes, some people don't recognize mental health conditions as illnesses. Instead, some people see a mental health condition as a personal weakness or a character flaw. And this really adds misdirected and unfair shame to the struggles of someone who's already dealing with a mental illness through no fault of their own. And this type of misunderstanding and lack of information about mental illness really is the root of the stigma that surrounds the topic. And it's making people feel uncomfortable about talking about mental illness. That's what stigma is all about, as far as the root cause and why it's such a harmful mindset. But personal, sharing personal experiences about struggling with a mental health condition, it really is the greatest barrier to mental. It's breaking down that barrier and we're working toward mental wellness. And because, like any other problem, the first step to improving mental health in this case is talking about the problem. But this also requires tackling the stigma that surrounds mental illness. And just speaking openly and honestly about mental health helps people share they feel like it's okay. Once someone hears someone talking about it, like getting and sharing your story, I'm sure is going to inspire a lot of people to, even if they don't necessarily speak openly about their situation, they're going to know that they're not alone. And to your point, Jason, about people feeling isolated and alone in rural communities, that's more pronounced. But no matter where someone lives, you can still feel isolated and alone. So until you hear somebody that shares your struggle, which is, both of you mentioned this already, but it just really is so critical to breaking down the stigma. Having the open forum to talk about what the mental health condition might be, and letting other people know they're not alone. But it's these potentially uncomfortable conversations really are the only way that we can work together to destigmatize mental illness.
Yeah, absolutely. I think about my own personal experience. When I was diagnosed with my eating disorder, I was living in Denver. So I was in a major city surrounded by a lot of treatment providers. I had a lot of options available to me. Now I live in Western Michigan, where I've got to travel a half an hour, 45 minutes just to go see a general practitioner. I don't even have access when it comes to maybe therapists or counselors and stuff like that. That's even farther away for me. And I know that Chuck, at your organization, you've done some research and you've got some statistics when it comes to access of treatment providers in small towns. And I was wondering if you could share some of that with us.
Yeah, for sure. And the situation you described, Jason, is very common throughout rural America. People find it really difficult to get an appointment. There's a severe shortage with mental health professionals and just healthcare providers overall. But some of the stats that surround that include a 20%, fewer primary care providers in rural communities when compared to cities. 65% of rural counties lack a psychiatrist, 47% lack a psychologist, and 81% of rural counties do not have a psychiatric nurse practitioner. So this, and along with that, there's an absence of insurance, or it's more likely to have insufficient coverage for mental health care, which is another barrier to rural mental health. And
absolutely,
kind of like going into some of the lifestyle barriers, we also find that in addition to some of the geographic challenges and some of the technological challenges, there's also that lifestyle barrier of what it means to be living in a smaller community. And a lot of people that are, in an area that's more rural, unlike if you're in a suburb or a city where your pipe breaks and you can call, pick up the phone and a van rolls up in your driveway the next day to fix it. When you're isolated and alone, you figure it out, you do it yourself. And that mindset of being independent, self-reliant, is often necessary to live and work in a rural community. But with that mindset, combined with the stigma that often surrounds a mental health condition, it can be really tough for people to reach out and ask for help. So that's a huge barrier that's kind of inherent in the rural lifestyle for many people. So people, they want to ask for help. And they're also afraid of being considered weak or incompetent. And there's also that confidentiality of being in a small, close-knit community, which can be a great thing as far as having people that might be there when you really need them. But also, a lot of times everybody knows your business, which isn't all that comfortable for some of them. I want to keep something private. And just that isolation too. It's and feeling like you brought this out as far as like you feel like a lot of times people feel like they're the only ones, that they're alone. And any marginalized segment of the population that somebody would find in a major city or a suburb, those folks are still in rural communities. They're just more isolated and possibly feel even more alone. So it's there's a lot of unique barriers to getting the help people need just by being in a rural community.
Yeah. Yeah, I can do it on my own. I've heard that many times before, and that's a tough thing because for some people that is that barrier to treatment, and then for other people it's entirely overwhelming. And I know for you, Gideon, you had to do a lot on your own to find those resources and make those resources. And I'm so glad that you were able to reach out and you were able to connect with folks because unfortunately so many people think they can do it on their own, and then they run into barrier after barrier, wall after wall. So I was wondering, Gideon, could you take us through kind of your experience of accessing care and accessing that support? I know the internet was very big for you.
Yeah. So I really appreciate Chuck mentioning the fact that like a lot of mental health providers and like physicians aren't even aware of like what to do with some of these diagnoses. Like I know as an adult when like going to a therapist or not a therapist, a counselor at my local county building and saying like, "Hey, I have ARFID. Help. What do I do?" And like she needed to reach over, grab the DSM and be like, "I don't know what that is," and flip through to find it.
Mhm.
And the response was essentially like, "Have you considered just eating the things you don't like?" And it's like mind blowing. I'm cured.
Yeah. Yeah, I've heard it before from people who say it's like a switch. Why don't you just start eating again? Flip the switch. And it's like it is not that easy. So many individuals, even treatment professionals out there, don't realize the complex nature of eating disorders.
Yes. And so for me, a lot of treatment was one, finding my community, realizing I'm not alone, and seeing what other people were doing as far as like food exposures. I that also led me down the path of finding health at every size and intuitive eating, which those were really beneficial when it came to the anorexia aspect of my eating disorder because I've always been in a bigger body. And so often, whenever I mention, like, hey, I don't think this is right, it was like, but you're fine. You can stand to lose weight. So finding health at every size and realizing that really the fear mongering from like pediatricians, they were off base. And, just because I'm in a bigger body doesn't mean I'm innately unhealthy. I have 27 years of proof and experience saying I am healthy.
Yeah.
And also intuitive eating and kind of using that reasoning of, well, if I follow my hunger cues and I listen to what I'm craving, I'll be better for it because one, my body is going to learn I will listen to it. And two, I kind of like trying to work with the eating disorder on that one and saying like, well, if I just eat what I want in the beginning, then I won't eat more later.
Mhm.
And trying to like get that buy-in from the anorexia.
Yeah, and as you were talking, I got to thinking about here at ANAD how things have shifted over the years. Prior to the pandemic, all of our support groups were in person. And now, since the pandemic, they've gone virtual, and we've kept them virtual for reasons like you just shared, because it gives you the opportunity to make those connections. And now, somebody that's living in a town of 5 people can connect with somebody who's living in a town or in a city of 5 million people. And it's so important because topics like that come up in our support groups all the time, health at every size or intuitive eating. And it's those types of conversations that I'm so glad we're able to bring to each other now through platforms like Zoom or the internet. But I know that also rural America lacks broadband access, and there are barriers there. So I was curious, Chuck, if you could elaborate a little bit more on that, and maybe where people can go to find some of those resources that they might need.
Yeah, well, many people in cities and suburbs are used to meeting with a healthcare provider online, which of course saves time and money. But in rural America, nearly 30% of homes lack access to broadband internet. And for many who do have access to the internet, the service can be unreliable or expensive. So this all adds to the barriers of potentially, having the option for a telehealth appointment. But to the point of all the amazing resources that are online, the Rural Minds website, and the address is ruralminds.org. All of the content there is free and accessible, and most of it is printable. So it can be a PDF that people can download and print off and share with people that maybe don't have access to the internet. And I think, in addition to a lot of information that's specific to the rural mental health challenges, there's also online access to a portal of content that's public facing, and there's just a lot of great information from so many mental health nonprofits that have been there long before Rural Minds, and in addition to many other organizations that have great free content. So part of what we do at Rural Minds is we do not reinvent the wheel. We want to give a nod and easy access to this information online, but we also want to identify, so what are the gaps that are, what are we missing for providing people in rural communities with all that they need for managing these challenges and getting the help that they need. And so that's where our focus is. But some of the challenges are common to people no matter where you live. So the portal that we have at ruralminds.org is specific to 3 different subsets of information and resources. The first is a webpage that's specific to crisis resources and support. And at the top of that is the new, well, it's not new anymore, but it's still not all that well known, 988, the 3-digit calling code for 24/7 mental health assistance. There are trained therapists that answer that, whether you're texting 988 or calling it. There's also a chat at 988lifeline.org. But the point is that it's not only an invaluable and potentially life-saving resource for someone who's in a crisis, but anybody can call at any time to ask a question, whether it's your question or asking a question of a loved one or friend that you care about and you're not sure how to respond. So that's invaluable. In addition to 988, there are many other resources on the Rural Minds website specific to crisis resources and support. And then we have 2 other pages. One is mental health resources by topic, which makes it really easy to just scroll down alphabetically and find what you're most interested in. Click the drop down, excuse me, and then you've got all these different links to organizations and resources, numbers to call, places to check out online. And again, all of this is printable as a PDF. And then the final one is just mental health resources A to Z. So if you're looking for a particular organization, it's easy to find that way too. So there's a lot of great resources, but and we try to recognize that while not everybody has access to the internet, hopefully by having the option to print these PDFs and handing them or mailing them to someone you care about or maybe looking for information is a nice option.
Yeah. Yeah, absolutely. And that brings up a really good point. And it's something that I've been trying to do here at ANAD is be really mindful of when we're putting content on our website, make sure that it is downloadable or that we can put it in a PDF format for people who might not have access to the internet. I've had people reach out here who have said, can you send me the PDF of some of your blog posts? I have limited access to the internet and I'd like to download this and read it on my own time. And it's one of those things that I encourage, if there's other mental health organizations out there listening right now or other nonprofits, be mindful of that when you're thinking about accessibility, that there are some people out there who need to have these materials printed for them. So anything we can do to make getting that information even easier, it's the best thing we can do. So Gideon, I'm going to shift the conversation back over to you again, and I would just love to get one thing that you would like to share with other individuals out there who might be struggling to find resources or might be struggling with an eating disorder, what would you say to them?
I think the thing I would say is I know it's a really tough path and it can be so isolating. But as cliche as it is, you aren't alone. There are entire communities online for this, for you. And, there is that light at the end of the tunnel. I also know, like, especially within the field of eating disorder work, there's a lot of emphasis on like a complete recovery. And I just want to hold space for the people who right now complete recovery isn't an option. And that like it's tough, but you're still valid. And I know like you're so strong.
I love that. I feel like mic drop right there. Like that's a powerful statement right there. And thank you so much for coming on today and for sharing your story because like Chuck mentioned at the beginning, it's through sharing our stories that we're going to break through this stigma and we're going to normalize these types of conversations. So I was really grateful when I was able to connect with you and you were willing to come in and share your story. Chuck, I would love for you to share just a little bit more about your organization and how the rest of us can get involved. What can we do to help support you and to help, attack that stigma and change this conversation so that we can have these openly and without shame or fear?
Well, thank you. Yeah, and that's so important. And at the core of Real Minds is we are all about partnering, and this is a huge initiative as far as mental health, mental wellness across the board, and in rural communities too. So we really are appreciate opportunities to have these kinds of conversations and to partner with individuals, with organizations. Rural Minds is the only national 501c3 nonprofit that's focused on providing free information and resources to confront rural mental health challenges, along with the stigma that surrounds mental illness for the 46 million people who are living in farming, ranching, agriculture communities, small towns, isolated areas across rural America. And, there within this area, there truly is a rural mental health emergency. And compared to people living in urban areas, rural Americans have higher rates of depression, higher rates of suicide, but they're less likely to access mental health care services, in part because of some of the things we've already talked about. But I think the stat that really drives home the emergency aspect of this is the latest research from the Centers for Disease Control and Prevention, the CDC. And they found that suicide rates among people living in rural areas are approximately 65% higher when compared to people living in large urban areas. And while it's important to recognize that, we don't want to just alarm people. We really, the work that we're doing is to provide the information, the resources, so people can respond to that. And we know that there's the shortage of rural mental health care professionals, and that, and combined with recognizing this independent, do-it-yourself mindset that's really common in many people who live in a rural community. Rural Minds has developed the Rural Mental Health Resilience Program, and the content was created really to empower people with the information, the tools they need. So wherever you're living throughout a rural community in this country, there's an opportunity to take it upon yourself to be part of the solution to confronting rural mental health challenges and doing what you're comfortable doing in terms of accessing the resources, the materials, the toolkit that's part of this program. And it's, as I mentioned, it's online. It's an access to free, culturally relevant, focused on the rural perspective as far as the mental health information, the resources to recognize some of these unique barriers that we've talked about that are specific to living in a rural community. So again, ruralminds.org. It also features recorded content from the Rural Mental Health Connections webinar series. A lot of great conversations with people sharing their personal lived experience of different mental health conditions, living in a rural community, combined with mental health experts who weigh in on additional information and content as far as how to confront those challenges and those conditions. And then we have another program about suicide awareness and prevention, along with, we've recently added tips on how to manage isolation and loneliness. That's actually on the main page of the website. There's a link to some information that's about, all about that topic. And we did touch on that during this conversation too. But everything's available at no charge. And folks can also sign up to receive the Rural Minds newsletter, follow us on social media, but I'm happy to do it. And we also have an info at email address. So if anyone has questions, if we can provide more information, we're always happy to do that, and all about partnerships. So thanks so much.
Amazing. Well, thank you for all the work that you're doing. And I was very excited when I came across your organization, and then when we were able to connect and make this partnership and collaboration happen. And this is just the first of many. This is the first of many conversations that we're going to have about this topic, because there are so many more questions that I have, and I know so many more questions that other folks who are watching right now probably have too. But we're running out of time here today, but I want to thank you both, Chuck and Gideon, again for the incredible work that you're both doing to erase that stigma and to help other people. And it's been an absolute pleasure to talk to both of you today. All right, so welcome back in, everyone. I hope you enjoyed that conversation. It was a real pleasure to speak with both Chuck and Gideon. And again, I think that's just another conversation that we're only just beginning, and it's something that we need to talk more about, because there are so many people out there right now who just feel isolated. Eating disorders already make you feel isolated, but then if you are geographically isolated from resources as well, we've got to do a better job of building that bridge and connecting everyone to the resources that they deserve. So again, I'm really appreciative for everything Rural Minds is doing. Definitely make sure to go check out their organization. It's a really cool one. I'm going to go ahead and close out this stream on my end, but you stay put, stay exactly where you're at on social media or on the ANAD website. We're going to close this stream out. I'm going to start the next stream up, and we're going to dive into a topic that I'm really looking forward to this one. Weight stigma, racism, and eating disorders. It's something that we could devote an entire day, an entire week to. It's something that we need to talk about a lot more. So I'm going to go ahead, close